Welcome to the Bronchiectasis and NTM Association podcast, where we're here to share valuable insight from leading health experts, heartwarming stories from people living with bronchiectasis and NTM lung disease, and the latest in health research and treatment. Please subscribe, follow us on social media, and visit bronchandntm.org to learn more. Just a quick note before we get started. This podcast series is intended for educational purposes only and is not suitable for medical advice. Please consult your medical provider if you have any questions. November is COPD Awareness Month, a time dedicated to increasing understanding and support for millions living with COPD. This year, the Bronchiectasis and NTM Association will be shining a special spotlight on the often under-recognized bronchiectasis and COPD overlap syndrome. When two conditions coexist at the same time, it can be challenging to diagnose and manage, but awareness is going to be the first step towards better care. In today's episode, we will be talking with Dr. Aksamit, Medical Director of the Bronchiectasis and NTM Association, to answer key questions about this overlap, including how common is it, the symptoms to watch out for, and what you and your healthcare team can do to help improve diagnosis and treatment. So stay tuned as we discuss how recognizing signs early and improving communication can help lead to more effective management and better health outcomes. Welcome, Dr. Aksamit. We are so happy to have you back today on this podcast. Let's start by talking about what is COPD overlap syndrome and how is it different from having bronchiectasis, NTM, or COPD alone?
It's great to be here with you, Alyssa, and our listeners today. And we're really going to talk about something that's very important and a very common occurrence with this notion of COPD overlap syndrome. And just for the record, we want to be clear of what COPD is, and that stands for chronic obstructive pulmonary disease, COPD. And just to make sure everybody's on the same page, bronchiectasis involves a scarring and a dilation of the bronchial tubes, and NTM, or non-tuberculous mycobacteria, is a lung infection of an unusual germ that normally resides in our environment and our soil and our water. When we start thinking about overlap, there are some instances where individuals will have primarily just COPD, which is most often associated with smoking-related types of lung problems, either emphysema and or chronic bronchitis. It's estimated that approximately 6 to 10% of the U.S. population has COPD, and what that looks like is somewhere between about 14 million patients in the U.S. with COPD, and it's estimated that about 500,000 individuals in the U.S. have bronchiectasis, and that's felt to be an underrepresentation of what the actual numbers are. This really brings us to this whole notion, however, that there is an overlap. That is, some individuals that have COPD also have bronchiectasis, and some patients with bronchiectasis also have COPD. The point here is that we want to address those individual diagnoses to help optimize treatment programs for patients. That is to say, if someone with COPD or carries a diagnosis of COPD also has bronchiectasis, that may be a very big opportunity to improve their symptoms and improve their clinical course by addressing the bronchiectasis that goes along with their COPD. The non-tuberculous mycobacteria can also have an infection in both individuals with COPD as well as individuals with bronchiectasis.
So the term overlap syndrome refers to when two different conditions, they coexist at the same time. How common are overlapping diseases with COPD, and who would be more at risk?
And that's another great question. And we don't know for absolutely certain, but I'll share with you that the most recent estimates by a large report called the Gold Report in 2025 estimated that somewhere between about 20 And 69% of all individuals with COPD have some bronchiectasis with a mean of about 54%. But not everybody with bronchiectasis has COPD. So again, COPD is a very common occurrence, and this is not uncommon. Somewhere between about a third and maybe even 2/3 of individuals with COPD have some level of bronchiectasis.
So, an increasing number of people with COPD are having CT scans as part of their diagnosis and follow up care, which is impacting the detection of these airway wall changes common in bronchiectasis. Would you say this is inadvertently finding bronchiectasis in people who may have early stages, or maybe they have symptoms or don't have symptoms?
Sometimes it's a component of both. That is to say, and I would really encourage our listeners if you've carried a diagnosis of COPD and if your symptoms have been refractory or you're having frequent flares, we call those exacerbations, to think about could there be something in addition to the COPD that may be contributing to why your clinical course is the way it is. So, very often, when patients are having breakthrough symptoms or recurrent flares that aren't responding to what we think is optimal therapy, they do get a CT scan, and very often, as noted, some level of bronchiectasis is appreciated on that CT scan.
I was reading about how they have increased the amount of CT scans that patients get because they're doing lung screening, like cancer screenings, and they were actually finding that there was early stages of bronchiectasis that even for people who didn't exhibit any symptoms. What would be some symptoms that a patient may need to be on the lookout for or have further conversations with their doctor?
Symptoms of bronchiectasis really are non-specific. That is, they're not unique to just COPD or unique to bronchiectasis, and they can overlap as well. That is to say, both of those will oftentimes have cough with sputum production, sometimes shortness of breath, occasionally even coughing up blood or having other symptoms that might impair their daily activities. So there's not really a set of symptoms that are unique to COPD or unique to bronchiectasis, but they overlap. And this brings us back to this whole notion that when patients aren't feeling where they think they ought to be at baseline and they're not responding to therapy, whether it's COPD therapy, to think about if they've not had a CAT scan, could there be other contributing factors? And in the situation that we're discussing here is could there be a component of bronchiectasis that also needs to be addressed? These very frequently get identified with the screening CT scans for lung cancer and other reasons to have CT scan.
How does COPD impact the risk of infections like NTM lung disease?
I think that NTM, this non-tuberculous mycobacteria, unusual organism that normally resides in our soil and our water, if there are refractory symptoms that aren't responding to the treatment for COPD or even the treatment for bronchiectasis, to think about that. If there are certain findings on the CT scan, we call mucus plugging, in addition to these dilated airways of bronchiectasis that are present. And when this mucus plugging occurs in the small peripheral airways, it looks like a branch with little buds on it, and oftentimes referred to as tree and bud infiltrates. When we see that, I think that we want to be mindful and certainly extend an evaluation for whether or not mycobacteria may also be present, these NTM organism. And what usually is involved is to collect some sputum. That is to say, in most instances of the COPD and bronchiectasis, patients will have cough with some sputum. And if the symptoms are refractory or they are continuing or they're not responding to therapy, we do want to collect the sputum for these unusual organisms of NTM.
Why do you think that bronchiectasis often gets overlooked or is misdiagnosed?
Yeah, this is another great question on why is this underrepresented or underdiagnosed. And I think to some extent it is a lack of awareness on the part of physicians and other providers, as well as patients. And one of the major initiatives of the Bronchiectasis and NTM Association is to raise awareness, not only for physicians and other providers, but for patients, caregivers, in the medical community in general. This is something that is far more common than what we were led to believe. We oftentimes talk about my younger colleagues hearing about bronchiectasis and NTM now in their medical school and medical training, whereas many of my other colleagues who are at a mid or a senior level of their career have had less experience with this. So raising awareness is, to a large extent, one of the components that we think is very important to identify the presence or absence of bronchiectasis.
So I was reading some articles, and of course, we don't know the exact numbers, but these articles were suggesting that there is a delay in diagnosis, or can be a delay in diagnosis, anywhere from 3.5 years all the way up to 17 years. If bronchiectasis is left underdiagnosed or not diagnosed, will this speed up the progression of COPD?
We worry that left undiagnosed, that it will lead to progression of bronchiectasis and irreversible scarring of the airways, which will then lead to impairment of lung function and more frequent exacerbations. So, to answer your question in a short way, and the answer is yes. Left undiagnosed, or a delay in diagnosis, we think is likely contributing to a accelerated loss of lung function and potential progression of underlying bronchiectasis with or without NTM in this situation.
So recognizing these symptoms early could definitely make a difference. So speaking of symptoms, how does having bronchiectasis and COPD influence treatment options and overall management strategies?
When it is identified that there's both a component of COPD as well as a component of bronchiectasis in this overlap situation, I think that the best approach to that is to take care of, in a parallel fashion, those aspects of care for COPD and those aspects of care for bronchiectasis. Some of that may overlap, but I think to unbundle that and to compartmentalize that, to understand that we want to take care of both conditions. And by doing that, it would be my opinion that this is a very manageable diagnosis, whether it's COPD, whether it's bronchiectasis, or whether it's a combination of this overlap of both COPD and bronchiectasis. So they are manageable, but we need to take care of each one of those components.
So, what are your thoughts on using corticosteroids when you have COPD and bronchiectasis?
Yeah, so that's a great question and a very common occurrence. Corticosteroids, or cortisone, hydrocortisone, prednisone, solumedrol, there are many different versions, are often used as a very effective anti-inflammatory medicine, including for lungs. We probably most commonly use this in the case of asthma when there's inflammation in the airways, which can also occur with COPD. And sometimes those steroids, whether it be prednisone or ICS, inhaled corticosteroids for COPD when there's inflammation present, can be a very important part of the treatment strategy. We also understand, unfortunately, that inhaled corticosteroids or prednisone may also increase the risk of infection. And as we've talked about with bronchiectasis, one of the components is recurrent airway infections. And so we try to minimize the use of prednisone or inhaled corticosteroids in bronchiectasis unless there's a good reason. That is to say, if someone has asthma or has a diagnosis of COPD that's been responsive to steroids, by all means, we want to continue to use the most effective treatment. On the other hand, if patients are having symptoms and course that's consistent with bronchiectasis, but not COPD or asthma, then we try to get patients off their inhaled corticosteroids or prednisone unless there's no reason to keep them on it.
So if a person thinks, we have our COPD patient, hopefully we have lots of people who have COPD listening to this, trying to stay informed about bronchiectasis and NTM. But if we have COPD, how do we start the conversations with our provider if we think that we might have bronchiectasis or if we're showing signs that we might have NTM lung disease as well?
Yeah, and I think that this is about shared decision making. And what that really means, in my opinion, is to have that conversation with your provider, to raise that as to ask him or her, do you think that this is a possibility? Could I have a component of bronchiectasis along with my COPD that may or may not be contributing to symptoms? If a CT scan isn't done for lung cancer screening or other purposes, and if we're having recurrent infections, more than one or two infections a year, at some point a CT scan should be done because that may take us down an alternative pathway for additional intervention or therapies that may be of benefit. So if a CT scan has not been done, and especially if there are ongoing symptoms that seem to be refractory to what the treatment is, those are conversations to have with your providers. And in most instances, if a CT scan has not been done, it should be considered, and it's usually very available in most healthcare areas.
I would say too, this really comes down to, being aware of what these diseases are and your risk for them. Because like you had mentioned previously, if you have a primary provider who is older and maybe they work in general practice and they're, helping you through your COPD, they might not be so familiar with these other lung diseases. So being informed is also very helpful, and being that advocate and talking through these symptoms and keeping journals, all of those things I think would also be really helpful in that
Yeah, and I think
situation.
that that's really an important aspect that patients and your caregivers are really part of the solution and not the problem. That is to say, to have those discussions to inform providers to raise that as a possibility, and knowing what you've heard on this podcast and from other areas of the Bronchiectasis and NTM Association, to try to understand and raise that awareness, because sometimes the providers haven't been as familiar or have heard about bronchiectasis as often as maybe individuals that are just completing medical school or medical training these days. So to advocate for yourself, to raise these possibilities really is important, and in most instances will be very well received, and will contribute to then trying to optimize the best treatment program. And sometimes we'll get a CT scan and there won't be much bronchiectasis, in which case we stay the course and treat the COPD with the treatment plan that was previously outlined.
So how does COPD impact the risk of getting infections like non-tuberculosis mycobacteria?
Yeah, we think that there's an increased risk for both individuals with COPD, but in particular, a much higher risk in those individuals with bronchiectasis, which involves the scarring dilation of the bronchial tubes, which is different than the chronic bronchitis or emphysema of COPD, although NTM, non-tuberculous mycobacteria, can be seen in both. And so we want to understand as well that almost everybody with NTM lung infections have a component of bronchiectasis, but not everybody with bronchiectasis or COPD has NTM. So when we have symptoms that are refractory, or we have CT or chest X-ray findings that aren't responding to our current treatment plan or cannot be explained, I think to think about the NTM is really an important aspect of care, and to raise that, could there be other contributing factors here, and NTM just being one of those factors to consider.
So you mentioned earlier that having NTM, it lives in the soil, it lives in the water. So what would be some ways that people could reduce their risk of acquiring NTM?
Yeah, so I can't tell you, and quote you chapter and verse on absolutes in this way, but trying to minimize some of the dust and soil exposures and some water exposures may be of benefit, but there's not hard data to support this unequivocally. So, for example, if someone is a gardener or in very dusty environments, it would be very reasonable that when working with the soil or working in dusty environments is to wear a mask to help protect us from that soil exposure, especially when it's dusty and dry. If we are to wear a mask in that situation, it really is important that it's an N95 or a K95 mask. A loose-fitting surgical mask really doesn't provide much protection for us in that situation. So many patients that I have with bronchiectasis, if they're avid gardeners, work with soil, peat moss, those sorts of things. To wear a mask when you garden is a very reasonable strategy. It does make breathing a little bit more difficult, so that's to be expected, but that should protect us in that situation. From a water standpoint, we generally think that these mycobacteria not only like soil and water, but they like high temperatures. So as a first pass, we generally say no hot tubs, no saunas, wet or dry, because that's a place that these unusual germs, the mycobacteria, like to hang out and be exposed to. There are some other potential mitigation strategies that you may want to discuss with your care providers, but as a start to minimize any hot tub or sauna or spa exposures would be a good place to start.
Lastly, what advice would you give someone who has been diagnosed with different overlapping conditions?
And I would start out and say education, education, education. And the pillars of awareness and advocacy are hugely important. Be your own advocate. No apologies for engaging, to ask questions, to hunt down information, especially as you mentioned, Alyssa, at the Bronchiectasis and NTM sites. There's lots of great resources and links to other resources that would really help inform us. And so that not only can we then increase our own awareness and be our own advocates, but we can then share this information as a community. But to engage in this is really important. This team concept that I think is part of the secret sauce to successful therapy doesn't only involve your providers, your primary care providers, any specialists, pulmonary ID, but yourself, your caregivers, and those around you in this way. And the more engaged you are and aware, I think the more effective your treatment course will be.
Well, thank you so much for joining us today, Dr. Aksamit. As always, it's a pleasure to have you.
It's great to be with you.
Thank you for tuning in to the Bronchiectasis and NTM Association podcast. We hope that you found today's episode helpful and inspiring. You can stay connected by joining our online community, following our social media, and visiting our website for more resources. And of course, subscribe to this podcast and join us next time for more insights, stories, and tips to help you live well with bronchiectasis and NTM lung disease. Until then, thanks for listening and be well.